very relevant topic for everybody, I think, as a general ophthalmologist, a specialist, because we all see in our practice that trauma is an emergency and that needs to be managed as the patient comes to us. So we should all know the basics. We should all know the first aid that we need to give to the patient and when to refer. That is something very relevant when you have to send the patient to a specialist for a surgical management. So that is what this IC aims at, telling you how to diagnose, what to do, the best you can do at your level, and then when to refer the patient. Also, these cases are medico-legally very hot, so it's very important to document properly for everything.
Maybe the second person can start.
I think we'll start with the second. We'll change the...
Oh, do you have a... Hello? Yeah, okay. A very good morning to you. So I'm going to very briefly tell you the basics of ocular trauma, the terms that we use, because subsequent speakers would be using these terms and zones. First and foremost, ocular injury is a major cause of preventable monocular blindness worldwide with a male preponderance. So there was a study which was published in Ophthalmic Epidemiology, the global impact of eye injuries, which said that almost 55 million injuries happen worldwide in a year, out of which almost 1.6 million people turn blind, and 2 lakh injuries are of open globe. This is a broad classification. Mostly we will be dealing with mechanical injuries in this IC. So there are few things which we need to know before we talk about the ocular trauma score, because few terminologies will be used for that. So any injury, depending on the breach of the ocular coats, can be divided into closed globe and open globe. Let's look at it diagrammatically. If we talk about the closed globe injury, that means the coat has not been breached completely. So we can have blunt injury, that is called contusion, or a lamellar or a partial thickness wound. So a blunt injury, the mechanisms are mainly two. There is a direct impact of the injury called as coup mechanism, and there is a compression wave force which causes the injury, which is called the counter coup mechanism. And coming to the open globe injuries, again, not only penetrating injuries, even blunt injury, which is very forceful, can cause the ocular coats to get breached. So that, in that case, it will be called as a rupture. If we have a laceration with a sharp object, that will be called as that will be laceration. And lacerations again can be divided into 3. We have the penetrating injury where we have only one entry wound. We can have entry and exit wounds, and there might be a retained intraocular foreign body. Coming to these zones, again, these are all prognostic indicators, so it's important to know the zones also. The anterior area covering the cornea till the limbus is zone 1. The injuries to the anterior 5 millimeter of sclera is zone 2, and anything beyond that is comes under the zone 3. And so we come to the open globe injury classification, where you have 5 types depending on the terminologies which we have used just now. It takes into account the visual acuity, the pupil, and the zones, as we have just discussed. And similarly, we have a closed globe injury. So now a patient comes to us in the OPD and asks us a case of injury, that what is my visual recovery chance? How do we actually decide that? So we have something called as ocular trauma score, called as OTS, and we'll just very briefly look at it. So for calculation, we need all this, okay? We designate the raw points, and then we calculate the OTS depending on this. So we'll have few examples, and that would make our lives a little easier. So this is the first example. This is a case of penetrating trauma. Vision, if I tell you, is hand movement. There was a retinal detachment with an APD. So let's go ahead. So depending on all these, we look at the raw points that we have. So it will be 70. For rupture, it's minus 23. For RD and for APD, we have these scores. We put all of these in the individual entities, sum it all up, and hence we have the raw score, the total raw score of 26. Now we go to this list. see where R26 comes to. So it's on the first category of OTS. So now we know, and we can tell the patient that there is a 74% chance that you will end up with a no light perception. And there is 1% chance that you will have a vision more than 20/40. So this helps us also to actually plan our treatment and to assure the patient and relieve his anxiety. So this is the second example, again a case of penetrating injury. Vision at presentation is 20/200 and there is no RD. So again, we go to this and start marking our raw points. Okay, so we have the total raw score in this case of 67. Come to this table, mark your 67. So we come to OTS category 3 and now we can tell the patient that there is only a 2% chance that you will end up with no light perception and a good 41% chance that you will have a good vision. In pediatric OTS, which is called as PAUSE, there are a few things that are added. So one of this is the age of the pediatric patient, and there are a few additions like injury with organic or unclean injury, etc. So let's see one example of this. 14-year-old trauma with a tree branch. So again, points towards an organic injury, visual acuity of counting fingers with an iris prolapse. Okay, so now if we go to this chart, counting fingers, and we have marked all the parameters. This is zone 1, obviously. Again, assign all the scores, and hence we have the score of 70. Go to the OTS table and mark our this thing. So this is again third category, 2% chance of NPL and a good chance of having a good vision. So for patients, for children who are pre-verbal, this is the formula that is used. So you take into account the age and multiply it by 2. So in a nutshell, all these are the poor prognostic indicators. Okay, if any of these are present with the patient, you know that somehow the patient will not end up with a good vision. So how do we evaluate? Important to step back, okay? Assess the patient as a whole. Look at the vital stats, the mental status, and always address the life-threatening conditions first, like fractures, etc. Now go to the history, and history taking has to be very, very brief. Actually, as you examine the patient, you have to keep, talking to the patient. So meticulous systemic history, the history of events. MLC considerations are very important. Dr. Arpana is going to talk about it later. Tetanus immunization, what is the last oral intake, because you might need to take the patient up for surgery. Coming to the ocular history, again, circumstances leading to the injury. We know the comprehensive eye examination, very important. Yeah, all these things. Pupils are very, very important. In case of an open globe injury, you don't do this. You don't check the intraocular pressure, and posterior segment evaluation many a times is actually not possible. Look for clues. There might be subtle clues. There might be acetals. There might be staining, okay? And IOFB can be lodged. There again are subtle signs. There might be an iris defect as seen in the last picture. We have seen patients with an IOFB lodged in the angles. So again, not at the first sitting, but you have to keep these things in mind. That's all. Thank you so much.
Thank you, Dr. Richa. That was a great talk. Now we have Dr. Arpana, who will be telling you the principles of corneal wound closure, which is basically covering all the penetrating injuries and corneal perforations.
Yeah, good morning, everybody. So, I'll be talking about corneal tear repair today under the topics of examination, counseling, suturing, and post-op care. Richa has covered very well the key history taking points. I'll go through them once again. Mechanism of injury, whether sharp or blunt, times is an injury because it is very crucial for contamination risk or if there's the iris prolapse. The baseline vision, the importance of that cannot be overemphasized. Last meal for GA planning, the immunization status and any allergies or any antiplatelet drugs the patient is on also makes an important finding. For the examination, we vision with visual acuity, the pupil, the shape, size, reaction or any RAPD. Serial tests should be done and documented. This on slit lamp examination, we document the wound extent, depth, and prolapse, if any. The IOP has to be a very cautious thing. Do not take IOP in open globes. Anterior segment, you have to see the hyphema, the lens, or any capsule tear. B scan is best avoided in open globe injuries. Now we come to the wound characterization. It can be linear, stellate, or an irregular flap. Location according to Betts classification, length, whether it is less than 3 mm or then extensive, whether it is self-sealing, the depth, the tissue loss. Again, it's very important. The corneal tissue, you cannot replace it much. If there is any vitreous or iris or lens prolapse, contamination, again, vegetable matter, soil, foreign bodies, and age of the wound, fresh versus more than 24 hours. Now we come to a very important part, which is the counseling and medico-legal documentation. The informed consent is very important. We have to tell the patient a risk of permanent vision loss despite repair, possibility of secondary surgeries like PKs, cataracts, retina surgeries, the chances of post-op infection and endophthalmitis, corneal scarring and irregular astigmatism is going to be there in all corneal tears, so better explain it. The need for GA, the risks of GA should be explained. Sympathetic ophthalmia, though very rare in this age, but yes, you have to talk to the patient about it, and we have to insist that a long-term follow-up is required. MLC documentation, all trauma cases ideally should be registered, but yes, if it is an RTA, if it is assault, you cannot get away with this. In Delhi, it's all online documentation now, but still that old paper file thing, that long thing, that also is there. You have to make an MLC. Wound description, very detailed wound description in the MLC sheet is very important. Describe the size, shape, depth, margins. Then, if any foreign body, again document. To see any intraocular foreign body, you cannot do a B scan. You have to resort to an X-ray or CT scan, or let it be, we can come to it later. If it is assault RTA, we have to intimate the police immediately. Wound photographs pre-op, before cleaning and after cleaning are mandatory. Vision on admission, this is, I suppose, the most critical thing to be documented. And surgical notes have to be documented very clearly. The number of sutures you've put, any challenges you faced, all that has to be documented in the MLC. This is good for you. So why prefer general anesthesia? I have done a few under local also, but it's not very good. An open globe, giving a LA is, you can never give a retrobulbar. Giving a peribulbar again increases the pressure inside, and it can increase the prolapse, if any. Now we come to the suturing principles. The golden principle is that the depth has to be 90% of the stroma. Too deep, you'll scar the descemetes. Too shallow, the seal will not be good enough. The bite width should be 1 to 1.5 mm on each side. Too close, cheese wiring will happen. Too wide, it is an irregular scar. More important than that is the depth of the bite on each side has to be equal. If you don't take it, if it is an irregular depth, one side you take 80%, 90% on the other, it is going to gape. If it is an old wound, a stellate wound, the sutures can be placed nearby, but don't tighten them. All the knots have to be buried in the stroma to prevent the vascularization. But practically speaking, I myself am not able to bury all the knots all the time. I resort to BCLs in that case. Avoid, keep the sutures parallel to limbus even when it is a stellate wound. I have a small video. See, we'll stop. How do I come back to it? Okay. The cardinal teaching is that you don't use the main wound to enter. But if it is a collapsed wound with prolapse, no AC, you have to inject the visco initially from the main wound. So in this case, there was a capsule tear. I was planning to do a cataract surgery along with. So I went and dyed this. capsule and did all that. Now we'll come to the suturing part. It's not working. Okay. So these sutures, I've put 3 sutures now. And you need to bury all the knots very nicely. After that, I did the cataract with the Simcoe. It's a lens aspiration with the Simcoe, no automated IAs. Another thing, I made 3 openings because it was a very irregular capsule tear. I want to insist, I'm talking about these 3 openings. They are well-sealing wound. But in corneal traumas, we have to suture all the openings. We need to suture our wounds as well. So now all is done, but as they say, the opera doesn't finish till the old lady has sung. See, there is a leak now. In the end, when I'm doing the hydro, I see a leak. Then again, I have to go back, put another suture so that I get a watertight wound, and then I put BCL in all my trauma cases, even if I've buried all the knots. Now, step-by-step suturing techniques. First, if it is a very bad wound, make sure that you do a minimal trimming. You have to preserve as much as corneal tissue as possible. First, the anchoring suture has to be put in the center of the wound unless it's a limbal one. If limbus is involved, the first suture always goes to the limbal. Every 2-3 sutures, test with Seedles for a tightness. Bury all the knots. If it is more than 24 hours, all prolapsed irises have to be excised. You cannot reposit them. And you close systematically from center to the periphery, form the AC, check for integrity again, and if sclera is covered, you need to cover the conjunctiva as well. Thank you so much.
Thank you, Dr. Aparna. Meanwhile, the next speaker can load the presentation. So I have few points of discussion for the benefit of the audience who seems relatively young. Do we always do a repair under GA? Because if I am a standalone practitioner and I have a shelf tier where I can do under LA, would you also go ahead with LA?
Look, I have a place where I'm very comfortable having a GA. I have a multi-speciality hospital. I have done a few. Sometimes it's like the anesthetist is not available. Sometimes it's like the patient has just had something to eat. You don't want to wait 6 hours. It'll go midnight by that time. But if it is a shelf wound, a self-sealing wound, you can give a very cautious peribulbar, but I personally don't do it.
Yeah, but that's what I was coming to, the accessibility. And so I think we have to titrate that. Do we really need to wait for GA, or this can be actually done?
I have a golden rule. I do it under GA.
You have the privilege.
Yes, I have the privilege,
yeah,
but I'm very comfortable doing it all under GA.
But yes, this because I'm sure all of you are residents also and must be doing a lot of emergency cases. We do routinely under local anesthesia as well, and because
I know,
waiting for a general anesthesia, the patient might end up in a government setup. Yeah. No. So next speaker, I think we'll have Dr. Anjali now. Or you have something?
Yeah, 1 minute. So another thing was burying the knots. Yeah, I understand sometimes burying the knot can be really challenging, especially if the wound is old and you're kind of causing cheese wiring. But to the residents, I would actually give a message that you have to bury the wounds. Otherwise, they would just get away by saying that it's not getting buried, and we were told that they don't get buried, because I think knot burying is of so much discomfort to the patient, and accessibility to BCL maybe has increased now, but in our times it wasn't there. No, so please bury the knots.
I'll give you a tip. You have to make the first knot, the tightness should be as you say, but after that the second knot and first knot has to be flush. The inability to bury the knots 99% occurs because your first and second knot are not flush with each other. You've not tightened it enough. The second knot should be tightened over the first one without tightening the main suture. If you've tightened the second over the first and the third over the second, there's no reason that you cannot bury the knots.
Thank you so much for
like there is corneal edema at the edge of the laceration, and especially the patients probably come after 2 hours, 6 hours. You never know. 2 days also. So by the time the edges of the lacerated cornea is become edematous and swollen, and moment you start putting, it's very difficult to flush them also. So of course, practice, and like Dr. Arpana and Dr. Neha has given you very, very valid tips.
There's another tip there. If you have edema along the edges, take the bites, long bites beyond the edema. Maybe
Yes.
2 mm on each side.
You
I've
might
done
think,
that also.
you might get some retinal folds ke kheech ke, but then go ahead, you have to do it. Yeah.
Okay, so now I invite our next speaker, Dr. Anjali. Dr. Anjali is a very dynamic ophthalmologist in Delhi, and she'll be speaking on lid injuries and canalicular injuries.
The background of the injury is important, as the previous speakers have said. In case of a lady with periorbital trauma, do keep in mind domestic violence. Supposing somebody has cat scratch injuries like this little girl, cats ke nails bahut deep hote hain and higher chances of infection, so be mindful. Associations are important. We have to see if there's a globe injury, then that takes precedence. Then if there is a foreign body, debridement is important. If there's a complex trauma, you have to plan it with a maxillofacial surgeon. Now coming to the lid injuries, it's important to know whether they are partial or full thickness, both the lamina involved. If the posterior lamina is also involved, then you'll have to do it in two different stages, sutures, absorbable and non-absorbable outside. But make sure that the deeper sutures are not through and through the conjunctiva, otherwise they'll abrade the cornea. It also is important what is the quantity of tissue lost. Up till 25% or 30% in lax skin, you can do direct closure with the famous pentagon that you all know. It's important that at the end of the surgery, the lips are everted. Earlier on, they used to say that take the first suture through the gray line. That no longer holds because that's actually a plane of least resistance. So just take one near the meibomian orifices and one in front near the lash line, and a double vertical mattress suture. Again, if more tissue is lost, 50 to 60%, then canthotomy, cantholysis, and a tensile semicircular flap, which I'll be showing in the next slide, is very useful. More than 50 to 60%, you have to do complex reconstructions. And this is a Cutler beard, a Hughes tarsoconjunctival flap is quite popular. And these you can see 5 stages of the Cutler beard flap. And sometimes later on, the patient, as you can see in the last photograph, may have dryness later on. And sometimes the posterior lamina, if you haven't reconstituted it with some material like, say, a tarsal graft from the other lid, it may invert inside. So here's the Tenzel's flap, which is very, very useful and very common on the left side. And all sorts of flaps are possible. When there's too much of a tissue loss and you have to reconstruct, then you have to take tissues which are matching. So for the upper lid, you can take skin from the upper lid, you can take supraclavicular skin or inner side of the arm, because the upper lid skin is very thin. It's the thinnest in the body, about 0.3 millimeters. For the lower lid, you can take pre or post auricular skin, as I've taken in this case. For making the posterior lamella, that is the tarsoconjunctival lamella, you can take a tarsoconjunctival flap. You can rotate it from the side if there's some left. You can take it from the other eye. You can use things like a nasal mucosal graft. You can use oral cartilage from the front here, tragus. Hard palate you should use only for the lower lid, because thoda sa keratinization hota hai. Don't use it in the upper lid because it can abrade the cornea. Nowadays there are latest materials which are being used like alloderm, natural polymers. Instead of taking the person's own tissues, you can use these external materials. And people are also trying engineered cartilage. An important point to note is that you cannot take 2 free grafts simultaneously. So either you take an anterior free graft or a posterior free graft. The other one has to have some source of blood supply. It can be a rotation or a pedicle or a sliding flap. And after doing the surgery, you can do adjuvants for better healing, like giving vitamins, making sure that the scar is not very rough by giving silicone gels, coconut oil, etc. And smokers always have poor skin healing, diabetics have poor skin healing, so you can address those things also. So special situations, like there's a lot of debris, it has to be cleared. If there's a dog bite, then you have to give rabies, you have to give tetanus, rabies immunoglobulin, etc. So based on the case. Now here are some examples of delayed repair. It can be quite gratifying. This was a lady who had trauma 12 years earlier and came now with a little cyst. And we removed the cyst and also repaired her ptosis at the same time after 12 years, so she was very happy. And this was actually an inclusion cyst. So the first repair, some little bit cells may have gone in, and this inclusion cyst formed after 12 years. So we published this case also. This is a boy who had injury, everything else healed, but his lower phonics refused to heal, and there was this kind of prolapse. So we formed a phonics, and later on he had a good result. Then this is someone who came with, I think, a dog bite scar, and you can do Y and double Z plasty, you know, different techniques are there. And scar management is a whole different ball game, which will take a full lecture. You can soften the scar with steroids, etc., etc. Coming to canalicular injuries, there are three things. First, you have to find the cut end of the canaliculus, the other cut end, medial cut end. Then you have to stent it. So I thank Nupur for these two photographs. So finding the other cut end is easy if in a fresh case you have this calamari ring sign, a white ring around pinkish edges, and you know you found the other end. Supposing you can't find the other end, then you can use adjuncts to finding it, like you can use methylene brew from the other canaliculus, you can use this pigtail probe, you can use viscoelastic, you can use air insufflated into a pool of water, and then you stent it, you put a stent, and then you do pericanalicular suturing with 80 Vicryl. Now, when you stent the cut ends, you have various options, and it's your choice. You can do only a monoocular stent like a mini Manoka. You can do a bicanalicular stenting, or you can do an annular stent. Sometimes people want to avoid the nose, maybe in a child, or maybe there are fractures there. They don't want to pass the ends through the nose. So you can just make an annular stent by passing proline through a normal stent that you use and making an annular placement like that. And for poor patients, you can just use your IV Venflon cannula, and you can even just suture it to the skin. You don't even have to do stenting. Something to keep that stent in place for a few months till it heals. A late repair sometimes is difficult if there's a lot of fibrosis. So people have talked about this innovative method. You take this endoscopic light pipe, and when you put it through the canaliculus, it really lights up the area, and you can cut down till you actually come to the light. And you can, of course, use it in fresh cases if you happen to have an endoscope with you. Coming to medial canthal tendon involvement, there are telltale signs. When the medial canthus is injured, there will be a rounding of the canthus, there will be telecanthus, it will move away from the nose. And when you reattach it, then the very important thing is attaching it to the posterior lacrimal crest. Early on, people used to do transnasal wiring and all that, but those are long, complicated procedures. Now it's simpler to just put a little plate. You have those micro plates which maxillofacial surgeons use. So you can just put a little micro plate there and suture the remaining tendon to it, or you can put a screw there. So this shows you the anatomy of the medial canthal tendon, and it has that posterior limb, anterior limb, and a superior limb, and the posterior limb is attached to the posterior lacrimal crest. You can see this dissector is showing you the posterior lacrimal crest, and for a good anatomy, you have to reattach the medial canthal tendon there, not at the anterior crest, because otherwise it will be a little utha hua from the globe. It will not be well opposed to the globe. The lateral canthal tendon is also very important, and the medial and the lateral canthal tendon, along with the tarsal plates, they form something called the tarsoligamentous sling of the eye. And this gives a lot of stability to the eye. Just have one slide left. This gives a lot of stability to the eye. So when we are doing our canthotomy or cantholysis, maybe with or without a Tenzel's flap, then we have to be mindful not to injure the palpebral lobe of the lacrimal gland. You can see it just comes under the eyelid. And the reattachment of the lateral canthal tendon is inside. There's the Whitnall's tubercle, which is situated a little 4 millimeter inside the lateral orbital margin, and that's where you should reattach the lateral tendon. And anatomically, studies have shown that the lateral the lateral canthus is about 2 millimeter higher than the medial canthus. So when you are realigning it, keep that in mind, or otherwise just look at the opposite eye. That's more important, that it should be symmetrical. Thanks. Here are some of my favorite people, and I say thank you.
Thank you so much for the talk, ma'am. I think we have some extraordinary results of your surgeries and they're amazing. But I want you to summarize in few words for the residents, like if they deal with a case of trauma and they see, because the flaps and all is not something that a resident can plan or do at that point of time. So first of all, should they even attempt doing this tenting and all? Because I think as a resident, I used to remember how to deal with the canalicular tear. You know, it used to give you sweat. You're the third year, you have to manage it. So till, you know, what is the point where they can manage and what is the point where they should refer either to the plasty or wherever? So that thing you delineate for them.
All right, that's a very nice question. And I think it depends on your confidence and whether you have a microscope. So if you have a good microscope, it's actually very easy to find the cut ends. You pass a Bowman's probe through the lateral end, and then you hunt around in the medial end, right? It also depends if there's a lot of periocular swelling and trauma or a lot of bleeding, right? So if it's a very puffy tissue, a lot of complex injury, then you just refer. But if it's a simple, injury, it should be quite easy for you to find it under the microscope and also to stent it, because you all do syringing and all that. Mostly the residents are only made to do syringing, so you're quite familiar with the canalicular system. But if it's a complex trauma, a lot of bruising and all, then you can refer.
And there was something interesting that you talked about, softening the scar with steroids. How do you do it?
You give a particular dose, and I haven't softened scars recently, but it's about, I think, 0.5 milligram. You give that same one जो आप देते हैं ना उसके लिए retina में tricot injection, about 0.5 small doses, and you leave it in place for 4 to 8 weeks.
Okay.
And that softens the scar a little bit. Some people put a little bit saline under it, and sometimes people use ये आपका Hexilac वगैरह आता है, these, or even coconut oil is excellent. So externally also you can soften the scar for some time before operating, and the results are a little better. But that is only in the superficial layer, right? For deeper layer, you need, of course, giving steroids and all, and it stretches the scar a little bit, makes it a little more supple.
So does it change the appearance aesthetically? Does it do that? Does it
Yes.
decrease the
I have
scar?
actually operated directly in most cases. I haven't had the luxury of long follow-ups.
Okay.
But colleagues who've operated after softening the scars find better results.
Better results.
Yeah.
Okay, great. Thank you.
The silicone gel sheets are more in when there's an ulcer and all that. They're fabulous, and they act like a kind of amniotic membrane, a synthetic amniotic membrane. And they help in actually healing of ulcers, you know, the ointments. Yeah, this is like in a already formed scar. People do it in other specialities for ulcers and all, diabetic ulcers and all that. They regularly use. Eyes mein itna haven't seen it being used, you know. I have not really seen any colleague using it. I have not used it. But for other I've used it for other parts of the body. So, any open ulcer, if you put amniotic membrane or you put these silicone sheets, it really helps beautifully in healing.
I agree, it works. I think we should move on to the next
All
talk.
right,
We can have the discussion later on as well.
So hi, I'm going to fill in for Dr. Neha Mehta. Unfortunately, she couldn't be with us today. So I'll be talking on challenges in traumatic glaucoma. So traumatic glaucoma is more common in males. Incidence is around 3.4% at 6 months and up to 10% at 10 years after injury. This is a very good study by Dr. Sehota and talks about the early predictors of traumatic glaucoma. So what are the main 4 things that has been talked about in this study was increased pigmentation at the angle, elevated baseline intraocular pressure, hyphema, presence of hyphema, lens displacement, and angle recession of more than 180 degrees. So they were important predictors. So let's look at some of the case scenarios. Here is a 25-year-old male, post-blunt injury. The presenting vision was perception of light. There was total hyphema as is seen here, and the intraocular pressure was 38 millimeters of mercury. Now we can have few, okay, what do we do here? Take detailed history, including any history of bleeding diathesis, any blood thinners that has been used. Ultrasound has to be done. A B scan should be done to rule out any posterior segment involvement. Medications that are used usually are topical steroids, cycloplegics, and anti-glaucoma medications. Propped up position, rest. So we can have few different scenarios. Suppose at day 7, the hyphema has begun to resolve here. Okay, the intraocular pressure has come down to 18. What do we do now? We can taper the AGMs and gradually, okay, not all at one go. We should wait for the hyphema to clear, because once it is actually starting to get clear, mostly it will resolve eventually. And we have to monitor closely. So the second case scenario, suppose the same patient comes to you at day 7, you see that the hyphema is clearing, but the pressure is high, okay, on maximum therapy, and the cornea is looking steamy. What do we do here now? We can do an AC wash, okay, can do a direct gonioscopy intra-op, can plan a trabeculectomy in the same sitting or in the subsequent sitting. So we need to take the patient up because the pressure is high. Again, a third case scenario. Suppose at day 3, you have total hyphema, which is not clearing at all. There is no improvement. Pressure is rocket high. What do we do now? Again, AC wash, and we can do an intra-op gonioscopy, look at the amount of AR, can plan a TRAB later on. TRAB or even MIGS works well in angle recession glaucoma. So what may be the complications of a hyphema? Number 1 and very important is corneal blood staining, and there can be rebleeding or secondary hemorrhages. So how do we actually know that there is secondary bleeding? The hyphema, suddenly it increases in size. There is a layer of fresh blood over darker clot. And here the incidence of glaucoma is 45 to 67% after rebleed. So important to look at these. And most importantly, if the patient is at a high risk, you know, if the patient has hemophilia, sickle cell trait, then you need to really monitor closely. So when do you actually wait and when do you intervene? If the hyphema is clearing, as we have seen in one of the case scenarios, the pressures are controlled, the cornea is clear, and there is no optic nerve threat, please go ahead with continuing the medical management. But if the IOP is high, there is signs of blood staining of the cornea, there is hyphema which is not responding to anything, and so we need to consider surgery early. These are the basic indications for surgery, you know, intraocular pressures and the days, and if there is any sickle cell disease, there is corneal blood staining, we need to intervene early. So one important thing is, in children, any visual obstruction in the form of blood staining may lead to amblyopia, so you'll have to take that into consideration as well. Here is another case of a 46-year-old male. He had blurring of vision since last 3 months. The pressures are like this, 20 and 36 in the left eye. On careful history taking, he tells you that 20 years back, he had a fist injury in the left eye. And this is how the eye looks. The right eye is okay. Left eye shows cupping. You do the gonioscopy, and you find there is angle recession in the left eye. So while doing a gonioscopy, important to note that always do the normal eye first, because even normal eyes may have a broad ciliary band body. So it's very important to compare both the eyes, okay? So do the normal eye first and then do the injured eye next. So typically, an irregular wide ciliary body band is visible with retroplacement of the iris root. This is how angle recession looks like. How do you manage now? So again, medical treatment, aquasuppressants are important. Pilocarpine should be avoided, and surgical treatment needs to be done when it's, you know, the pressures are high. MIGS works here. Filtration surgery or tube surgery may be needed in advanced uncontrolled cases. So angle recession diagnosed soon after trauma, but IOP is normal during first 6 to 8 weeks. We need to counsel the patient, but the patient has to be under annual checkup lifelong, because there are the risks that the patient might end up with glaucoma later on. What if you have a low intraocular pressure initially? Okay, there are few reasons for that. You might have a ciliary body shock, okay, that transiently reduces the aqueous production. A traumatic uveitis may lower the intraocular pressure, and importantly, there might be a cyclodialysis cleft. You will find it on gonioscopy. If angle recession is diagnosed later, uh, it can be suspected when you have a young patient with an asymmetric glaucoma, and there are other signs of trauma like sphincter tears, iridodialysis, a cataract, phacodonosis. And how do you miss it? Why do you miss it? Because the trauma might be years ago, and the patient might have forgotten about it. Okay, and if you don't do gonioscopy in such patients, you might miss angle recession. There are other types of traumatic glaucoma. So the first two are important: ghost cell glaucoma, hemolytic glaucoma. Again, look at the pressures. Aqueous suppressants may be, sufficient. But if the pressures are not coming down, might need to intervene. The last three are lens-induced glaucoma. So there might be subluxation or dislocation of the lens. There might be lens particle glaucoma, where the lens capsule ruptures, releases the lens material into the AC, and there might be a phacomorphic glaucoma. Again, important to control the pressures, important to take care of the lens. Might need a lens removal surgery, and decide upon doing a glaucoma surgery concurrently or later on. These are again some other types of glaucoma associated with traumatic glaucoma. There might be a steroid-induced glaucoma, because steroids are used post-trauma, so that may lead to an increase in intraocular pressure. There might be PAS developing, secondary angle closure. So these are few other things you have to look at in a patient with a penetrating trauma. Basically, you have to have, a good follow-up. And even if initially the pressures are controlled or they are low, later on in life, patient might have a risk of glaucoma. And watch the cornea. Just the numbers of the intraocular pressure is not enough. Gonioscopy, very, very important. It's not optional. Please compare with the fellow eye. Do the fellow eye first and then go to the injured eye next. Right, thank you. Thank you.
Thank you, Dr. Richa, for taking Dr. Midda's talk. So I just had a question regarding steroid-induced glaucoma, because I think that can be confusing for the residents. Like, they are managing a case and the patient is doing really well and the pressures start increasing. So it's my observation that whenever there is steroid-induced glaucoma, we do not have proportional corneal edema in that case. As in, like, the pressures when they go actually till 40, then we feel that the cornea is little steamy and the patient also looks really comfortable in steroid-induced glaucoma. Do you have similar observations?
That is true. So actually, if the pressure is rising acutely, only then you get corneal edema. If it's a chronic case, you might not have corneal edema. The pressure might be even 30, 40, 50, and the cornea is clear. So that can be there.
Yeah. Yes.
Yeah.
How much mannitol would help to reduce down if the IOP is very high?
So
Suppose like
actually,
50, 60.
I don't give mannitol much. If I'm planning to take up the patient for surgery, I would give mannitol just before surgery or intra-op, and then operate.
But on OPD basis, if they come, we generally give oral.
So usually, if you give Diamox 2 stat, it helps. It helps, but you need to continue
Monitor.
it
Along
and
with the
monitor the
topical-
patient basically. Yeah.
Okay.
And with topical. yes.
Topical, of course.
Also, there are 2 points. Yes,
Glycerol
any
can be
oral
given, yeah.
medication.
Glycerol can
No,
Oral, the liquid one.
Yes. See, mannitol is also, mannitol can also be given. It's just about availability and how much the patient can come, because it has to be given IV in your clinic setup and whatever. That is what is important here. 2 things that I just want to, 2 points I want to mention. One, if post-trauma angle recession glaucoma can come at any time. So you saw the case, it happened 20 years later. So post-trauma, it's important if the patient is ever giving you history of blunt trauma, do take the pressure in the disc. Also, in cases of traumatic glaucoma, the cause can be variable. So just jumping to a glaucoma surgery might not be a good idea. Treat the cause. If after treating the cause still the pressures are high, then go to glaucoma surgery. So if it's a lens induced, you have to treat the lens. So I think now we'll go to the next talk. Any more questions? We'll have time in the end. We'll take it that time. Dr. Sandhya Makhija is also an ophthalmologist practicing in Sant Parmanand Hospital, and she also has her own setup. And she will be speaking on traumatic cataract.
So good morning and welcome everyone. So going from anterior to posterior of trauma, so we after cornea and glaucoma and lids, we come to traumatic cataract, another most important thing. So it can be caused by, I thought this is working, blunt injury or penetrating injury, or it can be associated with capsule rupture or no, or zonular weakness or no. So this is just to begin with a baseline background I'm starting with. So a full assessment is very important. A detailed history, what is the type of injury, how is the mechanism of injury, what was the timing of injury, and then of course examination, complete ocular examination, visual acuity, pupillary examination, intraocular pressures, movements and everything, and slit lamp. All these points have to be very carefully seen, like cornea, capsule integrity is on use, is there any phacodonesis, is there any subluxation, do a gonioscopy, rule out intraocular foreign body, maybe a B scan or an X-ray, whatever the assessment needs. Because traumatic cataract is such a wide thing, you know, you have to like see case to case. Every case, you can't have a strict baseline that, okay, you have to go like this. So every case is a different case and, you know, you have to go by it. Then, of course, ultimately you have to plan for surgery. So there may be indications for early surgery or delayed surgery. So when probably you would like to plan for an early surgery. Yes, definitely in perforating injury, primary corneal wound repair, of course, ASAP. A delayed cataract surgery only if until the wound stabilizes and unless there's no lens material in the anterior chamber. If there is lens material in AC, of course, there is a risk of inflammation and glaucoma. Go in immediate, go in for aspiration because it's all loose. So just do a aspiration immediately or as early as possible. In pediatric cases, there is always a risk of amblyopia and it mandates a timely surgery. So you have to do all your assessments accordingly. In blunt injury, of course, then there you may delay a little bit and you have to look for other sequelae, you know, then you have to see whether the other sequelae, they settle down. And then, of course, then you can, and especially if there's a middle-aged or aged person or adults, then you can wait for a little while. Timing of surgery, it could be primary versus secondary. A primary extraction at the time of globe repair, like we already discussed, if there's a capsule rupture, lens in AC, there's a high risk of inflammation. Secondary extraction may be delayed by weeks, months, or whatever. It allows you to stabilize the eye and all the inflammation and other sequelae to subside and set in. Manage corneal integrity, secondary angle recession glaucoma as you might find. What are the preoperative considerations that you have to see? Control inflammation before surgery. Do a good foreign body evaluation. You might have to do an X-ray or you might have to do a B scan. If you feel there's a metallic, non-metallic, CT or MRI accordingly. So whatever, you have to go by those guidelines. Assess for the support of IOL placement because of course in future you will operate and you want to plan for an IOL. You want to know that what is the available support for IOL, which IOL you want to plan. Do an anterior segment and fundus assessment again before surgery. You might do a fundus assessment and all the anterior segment, slit lamps and everything, and you plan surgery, maybe a month later. So do that again because things might change. You might get some surprises. Do a B scan always, even if you feel that things are okay. It's always good to do a B scan, anterior segment OCT, a fundus OCT. Whether it's for documentation or prognosis or whatever, you must do it, in the times of today. So like this was a patient where this patient had a choroidal rupture and simultaneously a macular hole after a blunt trauma. So you never know what's happening behind. So before you start, see the capsule, whether it is intact or no. Would you be able to put a in the back IOL or maybe a sulcus IOL, if the posterior capsule is torn. If the support is totally inadequate, yes, you can consider scleral fixated or even retroiris fixated, whatever you are comfortable with, whatever your skill permits. AC IOL or FAK, of course, is the last option in days of today, and we don't advise it, but yes, that's an option. So these are the 7 rings of trauma I've just listed just for the sake of residents, especially if you're exam going. Lot of examiners will ask you, about these 7 rings on dialysis, 1, 2, 3, 4. I mean, let me not go into, you can just take a picture of the slide. But this is important as per your exam point of view. Okay, so where you will plan incision? Away from zonular weakness, you maintain the anterior chamber first, you titrate your size of incision. You must know that what you're planning after you remove cataract and what is your size of incision accordingly. Do a small incision, as small as possible, but adequate. You should not be, struggling or fiddling. Ports of bimanual IAs, you should know where to put. So that your idea is to easy manipulation of your surgical instruments, your hands and everything. Do a capsule staining, even if you're comfortable without it, but it's always better to do. Use Trepan blue to visualize the tears. You might find even some more extensions or, more tears. See vitreous prolapse, do anterior vitrectomy if needed. Hyphema or hemorrhage if it's there, perform washout if needed. Phacoemulsification is preferable for operable cataract or just a simple irrigation aspiration, lensectomy for thick absorbed cataracts or ruptured capsules. These are for later things, once they are absorbed and everything is settled down. Sometimes you see membranous cataracts, they require membranectomy with the cutter, with anterior vitrectomy. Be prepared for posterior capsular defects. You might find it. So that's how ASOCT is helpful. But even then, you might not get a full information on ASOCT. Keep vitreous cutter ready. Always your machines and cutter should always be ready for any surprises or any new things that you might have to use. Corneal or iridodialysis repair as the case demands, and it's always good to place suture in phaco entry wound also in the end, especially in children. A lot of people, they don't do it, but it's advisable. Plan combined versus stage surgery. When you have a corneal tear along with a cataract, use protective viscoelastic and avoid stress on the wound. Consider scleral tunnel pars plana approach if cornea is unstable, if wherever you find. And again, your IOL choices I just told you. If there's any vitreous disturbance, you look for the extent and location, again, the zonular support. The principles are the same, coming back again and again. Do anterior posterior capsule status assessment completely. Posterior segment status assessment is important. So manage accordingly. Cohesive or dispersive OBDs or vitrectomies, triumphs. So be prepared with everything. You might have to use anything. You don't know what's going to, help you where. Just to touch upon a little bit of iridodialysis repair, surgical repair is needed many times along with traumatic cataracts. If there's a large iridodialysis, more than 2 clock hour, do a repair. Cosmetically significant defects, do a repair. If there's a glare, photophobia, all these things, progressive or unstable dialysis. And non-surgical management, yes, you can do with small asymptomatic dialysis. If there's you can go in for a tinted or iris print contact lenses later on. There are certain ways of, sphincterotomies that you might have to do, because there's so many times you see posterior sinus case totally set in and pupil is fixed and non-dilating. So you might have to use these tools. So again, be prepared with all these tools. You never know where you would like to use a CTR or iris expanders and pupil expanders. So all those things you should be prepared with. If there's a subluxation, reduce your parameters. Put an incision capsular excess at the site of zonules where the zonules are intact. Use a dispersive OVD and use hooks to stabilize the bag. Do a little bit of anterior vitrectomy, gentle and careful. Do a gentle hydrodissection. Do a CTR placement if you feel it's required. A tangential cortical aspiration and a very gentle cortical wash, because you don't want to increase your subluxation, so you have to be like really gentle with your subluxation. If there's a detachment, like this case had a giant tear after blunt trauma, again after blunt trauma only. So there's a high risk after blunt or penetrating trauma also. So do a B scan if your fundus evaluation doesn't permit. And then management depends on the type of RD. You want to do a scleral buckling, and definitely these type of giant tears will need a full vitrectomy with silicone oil, with endolaser and everything. So these are the few images of different types of traumatic cataracts, a little bit of some iododialysis here, and traumatic, these are late traumatic cataracts associated with angle recession. And this is a subluxated cataract, traumatic cataract in middle-aged adult after a blunt trauma. These are again different types of blunt trauma with high FEMA, and these will develop a traumatic cataract later on, and we have managed them, say, even after 6 months or something. So these kind of posterior synechiae also set in after traumatic cataract. This is again subluxated cataract after, I think, 3 or 4 months of blunt trauma. This is a total posteriorly dislocated lens with a lens drop. And I just have few pictures, detachment after a blunt trauma. So I just showed these pictures for iododialysis, how to repair, which I just spoke about. There are different techniques, ab interno, ab externo, scleral tunnel, and how to repair these iododialysis. So let me go ahead. If someone wants to know more about this, we can discuss it after the course is over. And just a little touch upon how to go in for the post-operative routine post-operative management. And we have to just be careful about these complications. PCR, lens drop, and I will drop and delete. One case, little bit, one interesting case, actually I had a picture I just wanted to show you. Okay, this was a case where this was a young boy with a traumatic cataract. We had put a scleral fixated IOL, and unfortunately, after 5 years of SFIOL, again he had a trauma. The whole SFIOL, these were the SFIOL threads, at that time, like about 5, 7, 10 years back. So these also got broken, and the whole SFIOL again also got dislocated. So again, we did a revitrectomy and replacement of a big SFIOL, again another SFIOL. So this was after he regained 6/9 vision. So the whole idea is that you have to be prepared for anything after a traumatic cataract.
Thank you so much, Dr. Sandhya. I think cataract is the most interesting topic that everybody wants to learn about. But the most important thing that ma'am has told is document. Document the cornea, like Dr. Aparna said, document the cataracts, because right now you may be residents, but when you practice, that is the only savior कि ये सब कुछ था जब आप हमारे पास आए थे. So I think that is very important. And especially planning cataract surgery, you should not overpromise, because you just don't know what you're going to deal with. You may have a drop on table, you may have extension of the rexus, and I think premium IOLs may not be, usually advised to such kind of patients, because later on the patient can really get onto you, कि आपने इतना महंगा lens लगा दिया, पीछे the retina was not doing well. So these are few things that, I think we all know how to deal with these trauma and traumatic patients. And one thing that should be always told to the patient is that आज चोट लगी है, 20 साल बाद भी कुछ हो सकता है. So always follow up. Don't come back with a total glaucomatous optic atrophy. At least once a year, always see a ophthalmologist. Thank you, ma'am. So now I would like to invite Dr. Anisha. Anisha is a very dynamic vitreoretina surgeon from Delhi. So she will talk about posterior segment injuries. Over to you, Anisha.
Yeah. Please start the slideshow. Yeah, so one thing that ma'am said, Dr. Sandhya, once a trauma, somehow they are predisposed, and many times they do come later on with another episode of trauma. So that is true. Now, in the posterior segment, trauma manifests as so many things. While preparing the presentation, there was so much to cover. So I have just... एक second. इसको restart कर लेते हैं. So, I have not gone too much into the surgical part because it was a basic level IC, and I've covered all the conditions that we see in different posterior segment traumas, and what you as a general ophthalmologist can do as a primary treatment, and when do you need to refer to a retina specialist. So yes, thank you. Start off, yeah. I googled ocular trauma, and this is what we get. So eye trauma can be of different types, different causes. And this is the classification. The pathogenesis is basically the subcompression, anterior-posterior compression of the eye globe and horizontal extension. And this is what causes all the problem. It is moving on its own. The slide is going on its own. नहीं मैंने तो I've started it, it's going on its own. हाँ. No, I know, but it's going on its own. Front अपने आप जा रहा है. So, I have no time. So these are all the posterior segment manifestations that we see in cases of blunt trauma. The first is vitreous hemorrhage. Sorry, this is going on its own. I can't speak on each slide. The slide is just moving on its own. वो rehearsal पे जा रहा है बार-बार. It should not go. हाँ, करो. This is what we get in, there's a long list of posterior segment manifestations in case of a blunt trauma. The first is vitreous hemorrhage. Vitreous hemorrhage commonly follows and it results from injury to blood vessels in the iris, ciliary body, choroid, or the retina. And when you see vitreous hemorrhage, a patient comes to you, the fundus is hazy. First and foremost, look if the retina is attached or not. Second, look for any breaks. And the indicator is that you will see some pigment cells or tobacco dust in the anterior vitreous on the slit lamp. So if you have a hemorrhage, if it's a mild hemorrhage, you are sure the retina is attached, well and good, just keep the patient under observation. If it's too dense, do an ultrasound B scan to see if there's a retinal detachment, because these hemorrhages, most of the times, they're going to resolve on their own. And all you need to do is observe, except if the retina starts to detach or if the hemorrhage becomes organized. That means it becomes yellow in color. Second condition is Berlin's edema, again very common. It is caused due to blunt trauma to the eye, resulting in shock waves that damage the outer retinal layers. Appears like a whitish layering on the posterior segment, but sometimes in the, you see here, the periphery as well. The major site of disruption, as I said, is the outer retina. Now, depending upon the vision and the OCT, if the edema is less, vision is good, you can just observe with some NSAIDs, topical NSAIDs. But if it's a massive edema, the vision is very poor, it's always better to start high-dose steroids and topical steroids because you have to safeguard the outer retina photoreceptor layer. Second is the choroidal rupture, which is the most common thing caused because of the diagram that I showed you, the anterior-posterior compression of the eye globe, because the Brooks membrane is not as elastic as the remaining layers. So the Brooks membrane breaks off, the bleed occurs, the rupture occurs. Here, there are two types. There is a direct choroidal rupture or an indirect rupture. Direct is at the site of the injury itself, while indirect, which is more common, occurs at the posterior pole, where the Brooks membrane is the most commonly injured. Now, these present as crescent-shaped tears, most commonly associated with your subretinal bleeds as well. Many times, massive subretinal bleed is all we see in the acute cases. As the bleed clears up, we see the rupture as well. These ruptures, they occur as concentric circles, concentric to the disc. So as far as the management is concerned, in acute stages, only subretinal hemorrhage is seen, so we just need to observe. But if it is this large a submacular bleed, you have to refer to a VR surgeon, because here we need to save the macula. A vitrectomy or a subretinal TP or a pneumatic displacement would most likely be required. Now, prognosis depends upon, as in all cases of trauma, the location of the injury. Coming to the post-traumatic macular hole, again the same thing, as that is the reason I showed this diagram in the beginning. The macular hole occurs because the retina extends at the posterior pole due to the trauma. Now the good part is, the prognosis is good. Many cases will show spontaneous closure, as many as 65%. So to manage, if you see a post-traumatic macular hole, if it's a small child, amblyopia-genic group, then refer to a retina surgeon, because we can't afford an amblyopia. But in younger patients who are beyond the amblyopia age group, with small holes, good visual acuity, and most importantly, if vitreous is attached to the edges of the hole, still attached, then we can wait easily for 3 to 6 months. In many of these cases, the hole will close. But still, after 6 months, if it persists, then you have to send for a surgery. But if it's an old patient, a very large hole with a PVD already has occurred, there's no point waiting much, and we have to plan for the vitrectomy. This is a representative case where you see how nicely, because the hole is actually very small, so how nicely it has closed with time. Next, this is vitreous disinsertion or vitreous detachment. Very, very common, but probably the most innocuous condition. We're not worried too much about it till the time it is really associated with retinal breaks or dialysis. All we see is a hammock or a ribbon kind of a vitreous detachment moving in the vitreous, and the patient complains of vitreous floaters. At this time, screen well for any dialysis or tears, especially underlying the vitreous dialysis. Chorioretinitis, scleropateria, or chorioretinal disruption is a massive trauma, occurs generally with high velocity projectile injuries. Here, the retina as well as the choroid both get injured, and there's a break through and through between the retina and the choroid. So as it is like this, the patient generally presents with massive hemorrhage because there's a lot of bleeding from the choroid and the retina. As the hemorrhage clears, we keep doing an ultrasound. As it clears, eventually it ends up with this bad looking scar. Now, depending upon the location of the scar, the vision is there. If it's at the posterior pole, the vision will go. If it's in the periphery, the patient is lucky. Coming to the next topic, traumatic breaks occurs in about 10% of all cases of retinal detachment and are different types. We have retinal dialysis. Dialysis is a tear of the retina from the ora itself. There's a disinsertion generally associated with vitreous dialysis as well. And here, whenever the patient, very, very common in blunt traumas, when the patient comes to you like a ball injury or something, then screen well, and especially in the supranasal and infratemporal quadrant, indent well. That is something very important. You will see a dialysis if it's there. And if you see it, it gives you ample of time before retinal detachment occurs, so treat it. Cryopexy or laser has to be done for the dialysis to save the patient's eye. Equatorial breaks or other breaks due to trauma can occur at the equator, at weak points like a lattice or where the vitreous is strongly attached. So here again, they may be associated with a hemorrhage, and before the retina gets detached, it's always better to laser. For the patient and for yourself, laser. So the moment you see the tear, even with the slightest suspicion, refer to your retina colleague so that we can laser it. This is something that we are all very scared of, a giant retinal tear. It involves 90% or more of the retinal circumference, generally happens just posterior to the ora. And this needs an urgent surgery because the retinal detachment progresses very fast, the PVR progresses very fast, and it requires an urgent intervention. You can see it very easily, it's a clinical diagnosis. Coming to the optic nerve now, traumatic optic neuropathy is very common in blunt traumas, can be a direct injury because of a direct transection, an interneural hemorrhage, deformation, secondary vasospasm, avulsion, or a direct bony impingement into the optic nerve. Or indirect, which is more common, occurs due to surrounding edema or compression-decompression injury. You see here you see a small fracture in the lower here, a fracture, the bone is touching the optic nerve, and here you see a lot of edema around the optic nerve. So these are representative direct and indirect optic neuropathy cases. Presentation is sudden vision loss with an RAPD. You may see the fundus to be normal. Fundus might be absolutely normal in the early stages or may show some disc edema. Later on, definitely pallor is going to occur, but the catch point is RAPD with sudden vision loss, and rest, everything is okay. So when you see something like this, urgent high-dose systemic steroid is needed. Radiological evaluation to look for any bony impingement because that needs to be treated directly with the surgery. And if there's a compartment syndrome or there's a direct bony injury, then we have to send to our oculoplastic colleagues for surgical intervention. Optic nerve avulsion is a very, very serious condition. It's an extreme form of traumatic optic neuropathy. And here, the optic nerve is totally avulsed from the lamina cribrosa, and the vision totally goes away. So it can be partial or it can be complete. And here, this is the picture that you will see. You will see a crater kind of a thing around the optic nerve. Sometimes the bleed is so massive that you have to do an ultrasound or a CT scan, and that might also look out to be normal because in the optic sheath is generally attached. Only the optic nerve gets detached away. So in radiological evaluation, you might not find anything. But again, an RAPD with a PL negative status is what you need to be worried about. Treat urgently with high steroids, but the prognosis is poor. Coming to open globe injury. So open globe injury needs a repair. So first of all, the anterior segment, that you need to repair it first. And before repair, if possible, do an X-ray to document a foreign body there and explain the chances to the patient that posterior segment complications might be there. This is what we generally see: vitreous hemorrhage, RD, foreign body endophthalmitis, and sympathetic ophthalmia. When to suspect an occult globe rupture? You will see the patient has marked movements, very boggy conjunctival chemosis with massive subconjunctival hemorrhage, severe vitreous hemorrhage, the AC might be deep. IOP is usually on the lower side, but surprisingly it may be normal or even high sometimes. And this is when we should suspect there is some scleral rupture, and we need to go for a surgical exploration for repair. Vitreous hemorrhage, if we see, is the same. I'm not going through it again. If there's a retinal detachment after penetrating injury, it's a severe condition. Why? Because generally, it's either due to a direct retinal injury or more commonly vitreous incarceration into the wound. Now, that vitreous incarceration keeps causing a lot of inflammation in the eye, and eventually the RD has a lot of PVR, and the surgical result is very poor. So it's important that once you repair and the media is clear, we need to see the retina well to see for any wound incarceration, even if the retina appears to be attached. If there is any vitreous incarceration, we need to send the patient to a retina specialist. Intraocular foreign body is again a very common condition, depends metallic, it can be glass, it can be plastic, it can be vegetative, anything. Now here, infections are common in vegetative ones, and that is why we need to remove them early. Early detection by an X-ray or a CT scan, if we suspect a glass or plastic foreign body, maybe an ultrasound B scan, but they are difficult to detect. And if a foreign body is present, refer. So you see here, this is the first one is the CT scan. You see a large foreign body here. Yeah, here. And this is an ultrasound scan. You see back shadowing. This is very typical of a foreign body inside the globe. Here again, this is an X-ray showing a large foreign body inside. And important to diagnose iron foreign bodies, because if they are missed, eventually the patient from 6/6 will go to PL negative because of this. Sidrosis bulbi will occur. So that is where the responsibility of a general ophthalmologist comes, that the foreign body has to be picked up. Post-traumatic endophthalmitis occurs in 2 to 7% of penetrating injuries. Again, depends which organism. It can be any organism. Some are bad, some are good. But risk factors are if there's a delay, as we were talking. As we delay the repair, the risk of endoph will increase. If there's a foreign body, the large extent of wound, if there's a vitreous prolapse through wound, and if it's a vegetative matter injury, the risk is high. So when you suspect any of these risk factors, when you're repairing, preferably give a subconjunctival, intracameral, or even intravitreal antibiotic as well to cover for endophthalmitis. Early recognition is important, and this is just for the end, sympathetic ophthalmia, the last condition. Here, it occurs as an immunological reaction of the other eye to the injury that has occurred in the primary eye. So you see bilateral granulomatous uveitis occurring for no reason in the other eye. Also, suddenly the patient will have redness, blurry vision, photophobia, and we have to diagnose it fast and treat fast with high-dose steroids. Primary removal of the first eye is very rare nowadays because we can treat easily after an early diagnosis. To conclude, trauma to the posterior segment is extremely variable, shows any of these conditions. Primary management by each one of you is very important for eventual treatment. Good repair in case of an open globe injury is crucial, as hazy anterior segment is very difficult for a retina surgeon to manage, and many cases are medico-legally cases, so document, document, and document. Thank you for your time. Now I invite Dr. Neha, and any more questions, we will take it after the session is finished. This is our last talk, and this will be like probably a conclusion of the talk because she'll be talking about a firecracker injury case.
Yeah, good afternoon, everyone. So this is more like a summarizing, and it's more like a VR kind of presentation with no exam messages, but actually life lessons. So we all know that Diwali is the festival of lights, and it's so heavily celebrated in India. Luckily or unluckily, Delhi, we are blessed to have good smoke. So we hardly have Diwali now, and I feel happy about it because in my residency, I have seen both eyes go blind in 3-year-olds and 5-year-olds, and it's really traumatic. So probably for me as an ophthalmologist, Diwali used to mean more of loss of sight, and then God blessed me with 2 boys. So you can imagine. So yeah, the blinding truth is that the firecrackers do have a dark side, and it's major cause of preventable blindness, and it is about 18 to 20%. And we've been listening that trauma is more common in children and young males, but because the speakers, the audience are more of females, we actually aren't that safe because we are the innocent bystanders. Somebody is playing and throwing the pataka on us and everything is gone. So it becomes important for all of us because it has a huge socio-economic impact. And so these are some interesting videos I could find over the internet. The most common mechanism of injury, and boom, that goes into your eye. then we have these innocent bystanders. So we are seeing that guy is going and just flicked away the lighted up pataka, and then it goes into somebody else's house and causes the injury. And here we have a fancy guitar, just goes Ori. So making this presentation was actually very helpful. I was showing my boys, they were listening to my presentation, and I kind of instilled a fear in them, ki aram se pataka jalana. So, we actually have different mechanisms, thermal injury is very, those hot things that go into your eye actually injure it thermally. And so, like we were talking of end-off is little unlikely, like in the bombings and all, we found that they are already sterile, so they don't really cause end-off. And we have these chemicals in these patakas that actually cause a lot of chemical injury. We can have the blunt traumas, and then we have this penetrating injuries where these projectiles go through the ocular coats into the eyes. So it's all summarizing that we can have injuries. So we have to look very deeply when we are dealing with a firecracker injury, starting with the adnexa, whether we are having any lacerations either in the lid area or in the adnexal area, and then we have to evert the lids to look for the foreign bodies. Then we see the anterior segment for lacerations, abrasions, hyphema, subconjunctival hemorrhage. Any tear of the iris gives you a clue, that there is an injury. We have this distorted pupils, cataracts, and everything that has been discussed till now. And then we have one more thing, that's chemical injury that you might actually have to deal with. The posterior segment was very clearly explained by Dr. Anisha, where we can have varied manifestations. So management, I think whenever you are in clinic and you get a firecracker injury, the first thing is just inspect it grossly, because irrigation just doesn't start immediately. You have to look whether it is an open globe injury, because you cannot irrigate much then. And then irrigation typically is through a IV line, you just do blunt washing of it rather than a sharp washing through a syringe, which the old practitioners do. It has to be very gentle and very soft, because we might actually have occult tears. And then after you have done all the cleaning and the debridement, you actually go for detailed ocular examination, whatever is possible, slit lamp, direct, indirect. And imaging for a foreign body is very important. You should get an X-ray. I prefer a CT scan. We don't want to miss anything in private practice, because later it comes back to you bang on. And then surgical interventions as and when required, that all the eminent speakers have already explained. So this is a case one where we see the injury is mostly in the cornea, and it is more of a chemical injury. Since it has not been discussed, but I am not a cornea person, so I will just touch upon it, that washing like for even half an hour is very important, and debriding all the chemicals that you can see. Staining plays a very important role, just not with fluorescein but with rose bengal, because that also highlights all the injury that has been conjunctiva, because later this conjunctiva actually sticks onto the lids and then causes all the symblepharon, which we really don't want. Then steroids need to be used. I'm sure in our times using steroids used to be like, oh no, you can't use a steroid, but I'm sure all the residents are smart enough to understand the importance of steroids in chemical injuries now, along with cycloplegics, intensive lubrication. And here you need to know, if you feel that the limbal ischemia is too much, then you definitely need to refer it to the cornea guide for the AMG, because the AMG can be really salvaging and prevent a lot of ocular surface problems later on. So here we have a case, just a video to show how the injuries happen, and you see the lens is subluxated, and it also has phacodonesis, it has hyphema, and posterior segment was also not much visible. So that's the kind of trauma you get when it is blunt with a firecracker. And now coming on to a posterior segment case where the patient is initially having hyphema, and when you look back, you can see how there is subfoveal hemorrhage, and OCT is like that. So Dr. Anisha clearly explained how do we manage that, but if you are a resident or a private practitioner in the periphery who is not really having access to a VR surgeon, so you first have to prognosticate that you might have a choroidal rupture below. It has to be told, documented, because usually they do have. And you can also inject, if you are used to injecting intravitreal injections, then injecting gas gas and doing a pneumatic displacement is not a big deal at all. Take an isoexpansile SF6 injection. Just tell the patient कि जितना जल्दी हम displace करते हैं, we get better results. You might have a choroidal rupture at the fovea, so then the vision might not come well. Otherwise, there may be a good recovery. That will be told only when the blood displaces from the fovea. And you see, we have a choroidal rupture right at the fovea. This is so typical. The patient will never get a vision better than 618 or 612 unless he's really lucky. And the main thing of the talk is how an ophthalmologist can actually teach, especially when it is season, when Diwali is coming in your clinics. You can start running these awareness videos where you are telling how to actually light a pataka. It's like teaching a baby. And this video summarizes it for me all. You have to do it from a safe distance. You see that, interesting helmet that the child is made to wear. You can use protective glasses and always under an adult supervision. And this public awareness, I think, is one of the onus on ophthalmologists because people are coming to you, it just spreads. So that's the main thing. And I hope you like the talk. Thank you.
Thank you so much, Dr. Neha. That was very nicely compiled. And yes, a lot of things other than ophthalmology also she has taught us. Now we are open to questions. If anybody has any queries or questions, please, from the audience.
Yeah, I love the prevention part, and in fact, I think ophthalmologists are so successful in stopping that bow and arrow and giving
Yes. Yes.
That was a sustained campaign by our people only.
Yeah, because as doctors, it's not just about treating patients, but I think we should. Yes, that also. Recently, that was very recent. Yeah.
It
So our
was-
association also works on social messages towards managing and preventing injury to the eye.
I have one question for you, Anisha. If a CT documents a posterior scleral tear, what to do? No, no, I am not asking. What will you do? I'll refer to you.
Is it starting from behind or is it like anteriorly extending to the posterior side?
Whatever you tell, it's a hypothetical
Ma'am,
thing.
see,
Beyond, it's like
whenever we repair a sclera, we can repair it only up till, post
Equator.
disease, yeah, we can access. So
yeah.
we have to let go whatever is, and let the eye heal itself. There is only some limitation to approach to the eye that we can have. Also, I remember one of my professors always telling me, in case of an eye trauma in a surgery, don't jump into a surgery. See how beneficial it is going to be. So always see, because whatever surgical part, if suppose the large foreign body inside the eye, and you approach with the vitrectomy, you try to remove it, you might do a lot of damage during the surgery as well. So it's very important to weigh the benefits versus the risks of doing that surgery. It's true everywhere, but it's much, much important in case of a trauma. That actually, if the patient is PL positive, PR inaccurate, are you actually going to make his life better by the surgery? Is it going to be any beneficial to him to undergo that surgery, or rather make it more painful for him, or make it and he ends up into a painful blind eye? So it's very important to know which patient to not operate as well.
I think I have a point here for at least scleral tear repair. So if you have a corneal tear or you don't have a corneal tear and you have something like limbal and starting behind, so how do you approach? Because I think that is never taught. As residents, we just like kind of keep closing and bas ho gaya, now the consultants know, right? So the first scleral bite that you take, leave the suture longer, don't cut it. And now that's your pivot to pull the, and that is a very gentle pressure. And now as much as you can keep pulling, just keep going behind. And if you feel now I can't go behind, just stop. Secondly, your bite should not be too deep and too enthusiastic, because the tear might actually have not hit the retina and now your bites are actually eating up the retina. So these are the two things that you need to take care in scleral wound repair.
What about if you have in the past plana? How important is the cryo thing on the table?
No. If
Not
it is
nowadays,
within
no?
3.5, 4 mm from the limbus, no cryos.
Otherwise, also just do a primary repair and send to the retina. You will be surprised how well sterile perfs do, those who have not entered and most of them have not reached the retina. They are at the sterile level. You do a good repair. Astigmatism is not there because the cornea is intact. And once you have taken a retina opinion and everything is good, there is no incarceration. They do very well. They comes to 6/6. Vis-a-vis the corneal repair ones, because they will always have some astigmatism and some vision loss.
I think early reference just after you've closed. Just don't keep waiting for 1 or 2 months and wondering that should I now send to the retina specialist on. Finish and send.
Yes. In a day or two.
One question to both the retina specialists. When you have a collection of blood at the macula, till when can you do laser hyaloidotomy? And does it really help? Or
Laser hyaloidotomy is, it works wonderfully, but it has to be done in only specific kind of cases. Once the macula should be well covered, it should be a large bleed, and we normally do it at the lowermost edge, and it nicely at the thickest, highest. Now we have OCT also, and we see where the highest amount. We basically have to save the underlying macula and the fovea, but it drains out beautifully. It has to be, the level has to be subhyaloid. Sub-ILM generally doesn't work. So you have to know what the level of the bleed is, and it has to be, of course, a relatively fresher bleed. Works very well.
So in trauma that we are talking of, that's mostly subretinal that we are talking. There we have no role of hyaloidotomy. So hyaloidotomy is usually limited, like Anisha said, to either Valsalva retinopathy, where we are getting big bleeds, or sometimes we have aneurysms that rupture and you have that bright red color. Even in diabetics, it never works. However much you try, I don't know why we always keep wondering that they have such
because
thick
it's largely
blood.
sub-ILM in diabetics.
It
That's why.
doesn't work. It doesn't
okay.
work. You keep doing it because their hyaloid is thickened or what, it doesn't work.
Again, another very practical thing I would like to ask. I've done it. I've repaired the sclera. I want to send it to you. So how soon after the repair can you do a indentation and the things like that?
No, we would not like to indent. We are trained to see till the aura. Yeah, we will not indent. Yeah. Initially we would.
If the media is clear, there's no cataract, the pupil is dilating well. That is why it's always good to start the patient on steroids and everything. And if the media is clear, there is really most of the times no need to. And of course, we also will not just see once. We'll probably call the patient away again after a week and keep under close observation to see the area of the injury to look for any incarceration of the vitreous. Any more questions? Yes, please. Can we have the mic?
Hi ma'am, morning. So we do not have emergency OTs at our center, and we do get emergencies at night, like major open globe or corneal tear repair. And if we are referring such patients to some other center, what are the primary measures that we should be that should be taken care of before referring the patient?
So practically, honestly, nobody repairs it at that point of time. It's all in the books, repair as ASAP as possible.
I do.
And like she's saying,
I do.
no, she has a big hospital, so but like she's saying, she likes to repair it under GA. So 6 hours are anyways going. So I think the primary thing, if it is real and open globe, just patch and treat as early in the morning. You don't even need to refer because the patient may actually get lost. If you think you can repair it, then keep the patient with you.
Even if we are keeping it for next morning, any drugs that we should
No,
start then and
no
there?
drugs.
No,
anything?
I will differ here. You cannot instill antibiotic drops in open globes. If possible,
Moxie?
no, nothing. If possible, give IV antibiotics. Give one shot at least.
IV.
IV.
What are the preferable drugs that should be given IV?
Monosef.
Monosef is very safe. You can
Very
give
safe. You can. It has a very good renal profile. Anything. Give Monosef. Start. At least it will somehow maybe help the patient or not. It will definitely help you. End of हो गया. हमने तो एक antibiotic दिया था
and
जी.
do a patch because
Patch
it
is very
covering the
important.
eye. That's
And
all.
patch without ointment, without drops. Just a patch.
Yeah, and a hard cap. Hard cap is better because patch can still press on the
No,
eye.
it will not press. Hard cap. If you have, you can use.
Thank
I
you.
never use it. Thank you so much.
All right. Thank you so much for being so patient and listening to our IC. Hopefully, we'll all see you again. Yeah, bye-bye. Thank you.
Bye-bye.